First of all, thanks for everyone joining tonight, currently and in the future. Dr. Jahan Seuss is an assistant professor of surgery at the University of Minnesota. He completed both his undergraduate and medical education at the University of Virginia in Charlottesville, Virginia, followed by general surgery residency at the University of Minnesota and his surgical fellowship in the very warm Cleveland Clinic, Florida. His academic and clinical interests focus on understanding the role of the intestinal microbiome in health and GI disease. He uses basic and translational research to investigate physiologic changes that occur with surgical interventions with the ultimate goal of improving patient outcomes and he is doing some really incredible work. So we're really excited to have him speak tonight on the colonic microbiome.
Great, thank you so much for the intro. So I'm happy to participate in this talk and this group, and it's been going on quite a while. And it's really exciting to see that the education component in colorectal surgery is alive and well. So thank you very much for having me. Yeah, so what I'll be discussing is basically how we can understand the microbiome and then use it to our advantage and actually manipulate it to make it something that helps our outcomes. Because right now it stops at basically bowel prep. And what I'd like to do, my goal is to push it beyond that to make it flip the switch and actually help us out a little bit more and optimize it. So my main goal, our main goal moving forward is to regulate the microbiota to optimize recovery. Right now, like I said, we are really good at wiping it the heck out, but we don't do really anything to regulate its recovery afterwards, which has clearly been shown to play a big role in gut physiology, health, recovery, all kinds of stuff. So let's start a little bit basic, a little bit on what the microbiome does. The microbiome should essentially be viewed as its own organ right now. It does a heck of a lot. It's the definition of a symbiotic relationship between us, the host, and the microbiota, which on a cell-by-cell level even outnumber us 10 to 1 in our own body. So this is not an inconsequential area that we should be continuing to focus on. We provide the microbiota with habitat and nutrition. Like I said, they provide us with a heck of a lot, including but not limited to broad categories of metabolism and protection, metabolically, detoxification, vitamins, most well-known vitamin K, digestion, energy production in the form of short-chain fatty acid, which constitute 5 to 10% of our caloric intake, but also the microbiota is inextricably linked with our immune system, gut barrier defense, antimicrobial effects, and the microbiota themselves produce antibioses that keep bad bugs at bay. And then, like I said, the maturation of the immune system, not only locally, but also systemically. So what's going on recently? Well, for a number of reasons, you can kind of start to point to, most notably the Western diet and all the things that we're putting in our food. We are seeing a remarkable shift in the composition of the microbiome. This has been called dysbiosis, kind of a nebulous term, but by and large basically means we're seeing a remarkable decrease in diversity and an increase in bugs that favor inflammation. We're seeing increased endotoxins, impaired nutrient synthesis and immune defense, decreased permeability, which then favors translocation and inflammation, and then impaired energy metabolism. All this leading to inflammation that is mechanistically linked to anastomotic leaks, but also a heck of a lot of other things, including diabetes and cancer. But in this particular, our particular focus, anastomotic leaks and surgical recovery. So just a different view of what's happening with our composition. This is the composition at the level of the phylum. So that's the bird's eye view of the landscape, so to speak. So it's, you might remember kingdom, phylum, class, order, family, genus, species. We can talk about the species and the thousands of species there are, but this is kind of broadly at that phylum level. Broadly speaking, in a otherwise healthy state, Bacteroidetes is the predominant phylum, and Firmicutes being the second largest, but we're seeing this huge shift away from Bacteroidetes towards Firmicutes. So why is this important? A couple of decades ago, Nature, there was an article, that study in Nature that showed that not only was this this was just more than an observational study. This change in composition is associated with an increased capacity to harvest energy. So it's not the same for everyone to eat 1,000 calories. Some people will absorb more than that thanks to their more efficient microbiota that's being selected and driven for by the Western diet. So then why does it matter to us? Circling back to anastomotic leaks, this was the landmark study that out of Chicago with Dr. Shogun and Alberti that showed that uh, that in fact the microbiota, specifically Enterococcus fecalis, can contribute to anastomotic leaks. This was the first study that showed that there is in fact a technique independent explanation for anastomotic leaks. As we are all well aware, anastomotic leaks are devastating complications with major impacts on all kinds of things. Morbidity, mortality skyrockets from elective being less than 1% to up to 20%. And notably in the setting of cancer, a timely adjuvant treatment, specifically chemotherapy. As I mentioned, mortality goes up, healthcare costs triple, patients often need additional procedures, perhaps even a stoma, and then you just get in this tornado of things downstream. So by and large, this is what keeps us as colorectal surgeons up at night when we've created it. And we have a tough time predicting who's going to leak and not leak, especially since we don't really have any microbial markers that can tell us that information or how we can change it. This is even highlighted further in the fact that patients undergoing proctectomy for rectal cancer, of which now it's become standard of care to undergo total neoadjuvant therapy, even themselves undergo routinely proximal diversion with the diverting loop ileostomy. So cannot be overstated the effects of anastomotic leaks. What about the role of the healing with the microbiome? So yes, there are bad things it could do, but there are also a remarkable array of things it does positively from a healing standpoint. So specifically, following injury, the mucosa undergoes significant changes with a microenvironment characterized by cellular migration, proliferation, and tissue remodeling. What's been shown, though, recently is that the microbiota specific bugs actively play a role in that cell recruitment, so in part driving gut healing. This is really well shown in germ-free mice, so mice that are born without any bacteria whatsoever, gut basically denuded of bacteria, and they have impaired epithelial migration and delayed wound healing. So they play an important positive role on healing as well. So let's take our current clinical scenario that is pretty routine for colon surgery. Let's say you have a patient who underwent a colonoscopy and found a cancer. Now they are presenting for an elective partial colectomy for a non-obstructing cancer, pretty standard presentation. They would, by and large, majority of the time, receive surgical bowel preparation, which is the combination of mechanical cleansing and the oral antibiotics the day before. They get some more antibiotics on the day of surgery. And then they just hang out in the hospital. We don't really do anything with the fact that we just cleared them out of stuff. And that's that. They go home, that's that. Hopefully they don't leak, right? So let's go back up and talk about that bowel preparation for a second. There's a lot that even then with bowel preparation needs to be delineated. Certainly clinically we studied it, but what happens from a more physiologic level with the microbiome, since that's basically the target of our bowel preparation. So 50 years ago, early 70s, Dr. Nichols and Condon introduced their PrEP. In other words, selective gut decontamination. Obviously there was a pendulum that swung back and forth with do we prep, which components to give, all that. But by and large, more recently, a few years ago, was a very nice trial, the Mobile 2 trial in Europe that showed that surgical bowel preparation, the combination of the two, reduces anastomotic leaks and surgical site infections by 50%. So very effective. That was the study that we needed, that we were looking for, that gave us that added assurance that what we're doing is important. But even with that 50% rate, infection rates in our field are still unacceptably high, suggesting we're still not optimizing perioperative protocols to reduce infection risk. So what does bowel preparation do? In other words, to make things better, how can we make things better? First off, we have to backtrack a little bit and figure out what bowel preparation does to the microbiome. So in nice surgical fashion, we try something that works, but then it's nice to figure out why it works so that we can truly make it a little bit more effective and efficient. So this is where our group started looking at some stuff a few years ago. We initiated a prospective study just to understand what happens after surgery. This is led by one of my partners, now partners at the University of Minnesota, Dr. Butts. We started this around 6 years ago, prospectively looking at 3 arms for specific reasons. Number one was a colonoscopy arm. That's our arm where we give mechanical bowel preparation. The utility of that arm was to take a look and see what happens with just plain old mechanical cleansing of the colon, right? Get rid of all the stool effluent and see what happens when it's denuded in that regard. Second arm was a non-resectional surgery arm. In other words, this is an arm that gets bowel preparation, full oral antibiotics, IV antibiotics, plus mechanical bowel prep without resection. We do this routinely for 2 particular groups of patients, patients undergoing ventral mesh rectopexy for rectal prolapse, or patients undergoing TAMIS, transanal minimally invasive surgery. The third group is your resectional arm, basically patients undergoing same bowel prep, full bowel prep, oral and IV antibiotics, plus the mechanical bowel prep with a primary anastomosis, lefts or rights, basically your partial colectomy with a primary anastomosis. Initial publication, we had 10 to 12 cohorts. We just completed the study with 25 to 30 patients, and we assessed the microbiome at 5 time points: before surgery at baseline, day of surgery after bowel prep before intervention, and at 1 week, 1 month, and 6 months, just to see what happens acutely in the intermediate and then way out longitudinally. By and large, we found that our bowel prep is not exactly doing what we exactly wanted it to do. At this point in time, with that bowel prep, we are seeing greater abundances of Enterococcus and Streptococcus, particularly with non-resectional and resectional cohorts. Just looking at a graded scale, we don't really see any changes in mechanical bowel preparation. We see obviously significant changes here in this chart in the middle in this graph with Streptococcus and Enterococcus after non-resectional surgeries. So let me go back and clarify that the y-axis is going to be your relative abundance. So basically the percentage of all bacteria remaining in the colon as we identified in poop is what's delineated here, reflecting Streptococcus and Enterococcus. So then after non-resectional surgery, Enterococcus and Streptococcus both skyrocket for up to 10 days after surgery. And then what's interesting is that if you add the resectional component, that goes up even higher, which is, I would argue, the exact setting that we do not want that going on. So Enterococcus, we know, as I showed before, that is clearly associated with mechanistically with the occurrence of anastomotic leaks. What I didn't show before, just to give a little primer on Streptococcus. Streptococcus, first off, we don't know why exactly Streptococcus explodes in the gut. We theoretically shouldn't be seeing that, considering the broad coverage of the antibiotics, especially against gram-positives. But we are seeing this, and notably in other contexts, Streptococcus in the gut is terrible, really, really bad. Why? It's a lactic acid producer that drives down the reconstitution of your commensal health-associated bugs, which produce short-chain fatty acids, So, and I mentioned this change occurs most dominantly with surgery, but let's talk a little bit about short-chain fatty acids as well as Streptococcus. So Streptococcus, just to take a stab at this, we think it's coming from the mouth. We're testing that now, but we'll know in a few weeks if that is in fact the case, which might change things, kind of put things on their head, so to speak, as to how we think about gut recolonization after surgery. So by and large, there's one message here. Oral bacteria going to the colon is really, really bad. Streptococcus, we kind of had this hypothesis because Streptococcus is the #1 most dominant taxa in the mouth. And so what's been shown is that ectopic couple of very high-level papers showing that oral bacteria going from the mouth to the gut is really bad, in other words, inciting inflammation, also being linked to IBD as well as colon cancer, specific bugs, namely parvomonas from the mouth causing colon cancer. So why are we seeing this imbalance? Well, it's because the mouth actually is a close second in its density of bugs to the gut. We're wiping out the gut. We also drink basically about 1.5 liters of saliva a day. And so we've created this imbalance, potentially linking, making it easier for oral bacteria to make it down in the gut. That's a thought. We're testing that. We'll have results later on to see if that is in fact true. Not sure where else the streptococcus is coming from, to be honest with you. And then enterococcus. So that clearly is linked to leaks. We're not covering that. That shows that I would call our prep, at least while it's somewhat effective, still inadequate. So perhaps thinking of some other antibiotics to test that oral antimicrobial coverage down the road. So what about the good bugs here? So these listed here are some of those short chain fatty acid commensal health associated bugs that I mentioned. So these bugs, basically, if you're looking specifically at post-op day 10 and beyond, really in general go down quite a bit relative to, especially in the resectional arm from left to right. In particular, the bugs in green down below, Ruminococcasiae blautia and Fecalibacterium, very well established short chain fatty acid producers plummet, especially after bowel prep, most notably on post-op day on day of surgery, so post-op day 0, as well as post-op day 10, before they start to climb and recover after that down the road. What does this do? Well, in the figure in the top right is butyrate acid concentration. Butyrate is a critical short chain fatty acid that has clearly been linked to, in especially animal models, to reduce the occurrence of anastomotic leaks. So that's been known some time. Globally, we see short chain fatty acids decrease by 90+%, primarily in the arm where the short chain fatty acid taxa are being most damaged. In the resectional arm, again, what I would argue the most important one of these three, considering you have an anastomosis that's healing. These changes, beyond these bugs, certainly, a lot of these changes can be seen up to 6 months post-op. So one day of doing something can last for a long time, and the consequences are still significant, and there's room for improvement here. So I talked briefly about Streptococcus enterococcus, just another primer on short chain fatty acids. As I mentioned, butyrate is a well-established short chain fatty acid healer, short chain fatty acid that enhances colonic anastomotic strength, broadly promotes epithelial growth and gut adaptation, and they have a clear and well-established role in modulating inflammation and aiding tissue recovery. So altogether, a lot of things that we have well established that we're still not optimizing with our current perioperative regimen. So other side points, we did compare diverticulitis in cancer patients and found that diverticulitis patients had the most significant changes, likely because of their repeated hits to antibiotics for the treatment of their itis episodes. And then resecting left versus right had similar compositions. So anatomy, perhaps while it may have a role in impacting composition, is probably being overwhelmed by the nuclear bombs from the antibiotics and the prep that we're giving. So then, just to summarize, based on our data, why would we consider gut microbial reconstitution? Well, we would hope to achieve 3 things. There are some things to improve on. 1, a reduction of Streptococcus and Enterococcus, bad bugs based on in other settings as well as our own. 2, well, if we reintroduction of health-associated commensal bacteria, they themselves, the presence of them should help us improve gut healing. And thirdly, byproduct of them being reconstituted, restoration of short-chain fatty acids. So is FMT, what we used to call fecal microbial transplantation, feasible in colonic surgery. So this was a project led by Dr. Sonia Boatman. She's one of our chief residents who's staying on for fellowship here at the University of Minnesota. She designed a beautiful study in a mouse model of a colonic anastomosis. So I've got her video running on the upper right corner. This is basically what she did. It's a mouse model of colonic anastomosis. So we try to mimic everything. We're surgeons, so we try to make everything as translational as we can, obviously within the realm of what we can do in the mouse model of surgery. The mouse is on its back, supine. So head is towards the top of the screen, feet is down. The screen left is the right side of the mouse, and as the screen right is its left side. What Sonia did here is she became incredibly efficient at these, efficient and proficient. So this is a lower vertical midline incision, maybe 1-ish, 2 centimeters in length. She basically is able to identify the end of the colon there in the mouse, pull it up with excellent retraction, and then she performs a complete transection of the bowel, and then reanastomoses it in interrupted fashion with 8-O-proline, all using her bare eyes. No, I'm kidding. She's using a microscope, obviously doing all that. So then you're seeing her she puts in her corner stitches first, and then goes in between. This is a complete transection that she ends up with. So while that video is, she spins it around, makes sure she gets the posterior part, all that kind of stuff. So she does a pretty cool job. And then what you'll see at the end of the video is we actually do our own air leak test. She inserts a catheter transanally, blows air into it while the belly is filled with water to look for bubbles, and then she'll reinforce wherever she sees bubbles. So truly making it like we try to do in real life. So what she did was she took a set of mice, 2 sets of mice, placed them on 2 different diets. One group got a lean diet, lean healthy diet, LD group. The other group got the Western diet, high fat, high sugar, low fiber diet. Really a terrible diet that's terrible for you. Mice in general with the Western diet have higher leak rates than lean diet. What she did was on the day of surgery, so she kept these mice on these diets for 8 weeks. And then after 8 weeks, she gave mice that had been on the lean diet, she took their poop and gavaged them. So basically gave the mice who had been on a Western diet a transplant from lean, healthy mice. So the hypothesis there is that although these mice had been on a terrible Western diet for 8 weeks, if they get the bacteria from lean diet mice, that might impart a protective mechanism against anastomotic leaks that's standard with Western diet. And what she did indeed find with that study was that mice that received, so Western diet control mice that did not receive any transplant from lean diet mice had a much higher leak rate than Western diet fed mice that received lean diet. And so this was pretty cool. She did this a couple of times, and clearly there was a benefit here of changing that gut bacterial profile on the day of surgery. So that was pretty cool. This was our preclinical study to help suggest a kind of a proof of concept here. So then let's move to people. Mice and stuff are fun, but the key is we're trying to do this in people and identify a translational effect and a benefit. So let's go back to our clinical scenario. Currently, there are no protocols that regulate the microbiome composition after surgery. That point we've made. And so what our prelim data shows, and data from FMT studies for C. diff, colitis, which is now the standard there, shows that the microbiome is a potentially modifiable target to hopefully improve outcomes. So then let's talk about how we design a post-surgical protocol. Do we give bowel prep or do we not give bowel prep in these patients? Definitely. Let's give bowel prep. Let's give bowel prep and wipe out whatever the heck is in there so that we can hopefully get a nice ecologically friendly environment for our new bugs. What about the IV antibiotics at the time of surgery? Well, we have to wait. at least our institution across the board, the majority, the most common perioperative antibiotic regimen is ANSEF, so cefazolin and metronidazole. Each of them have half-lives of 6 to 8 lives. We'd have to wait 48 to 52 hours to give healthy bugs back, because otherwise the bugs will die if we give it right at the time of surgery or shortly afterwards. So that's 98, that 6 to 8 half-lives achieves 98% clearance. So hopefully the stuff that we would like to get back survives. How do we give it? Colonoscopically? No way. That's a standard for C. diff, but you're talking about a brand new anastomosis that me having a true love of the microbiome would never do in the setting of the risk of disrupting your brand new anastomosis. So what about it above? So how about a post-pyloric nasojejunal feeding tube, something that you can easily slip past the antrum, hopefully slip past your gastric acid plus your bile. And then lastly, do I get my own stuff back or do I get the good stuff? No way. You get healthy stuff. You get some stuff that we've been made, because what we recognize now is that the microbiome definitely plays a role in, or at least not definitely, highly suspicious, obviously, that it plays a role, likely plays a role in the occurrence of whatever we're doing surgery for, whether it's diverticulitis or cancer. Very strong data supporting both. So if you have those, then it doesn't, at least to me, it didn't really make sense that you'd be giving your own stuff back. Perhaps you're going to get something with a little bit more diversity in short chain fatty acid production. So can we do it in people? The short answer is yes. We just finished our first phase 1 trial, looking at exactly doing that. So we inserted a post-pyloric feeding tube. Obviously, there's a phase 1 trial, FDA approved, using what we standard material for our C. diff patients. So it's been used for a few hundred C. diff patients, just repurposed for our surgery. So we did this in 12 patients. We had no infectious complications in our 12 patients. All patients underwent the same operation, a sigmoidectomy for either medically refractory diverticular disease or sigmoid colon cancer. Right off the bat, if we're talking about diversity, Shannon index is a measure of diversity of the composition. We found a significant increase in diversity in transplanted patients versus their non-transplanted cohort from the initial studies that I had presented to you. What about Streptococcus and Enterococcus? Well, we found that these bugs, in particular Streptococcus, plummets right after surgery. So on the figure on the left is our control group that did not get transplanted. Our MTT group is the microbiota transplantation therapy group. We found that we saw a similar spike at day of surgery, but then we saw that by day 10 to 14, when we collected our stool samples there, both plummeted. Streptococcus in particular significantly plummeted at that point. What about our healthy bugs? So this is the same few group of same well-known short chain fatty acid producing bugs, Blautia, Lactospiraceae, Ruminococcacea. We found that control arm on the left, you see that these groups do a day of surgery go down as they're trying to rebound, but basically after MTT, we see significant increases in all 3 of those taxa as well. So these are at the genus level, so including just 1 level up from species. So we're seeing the right changes we wanted to. Specifically here, short chain fatty acid producing commensal bacteria return earlier. What about the function of the microbiome? In other words, short chain fatty acids, what happens to them? So interestingly enough, our short chain fatty acids go up 8-fold after the transplant. So it's not a little increase, it's a huge increase that we saw. So the top group, the microbiota transplant group, these are the 3 biggest well-established short chain fatty acids: acetic acid, butyric acid, propionic acid. What I have circled in green is the transplant group. So you go from an average of 47, 16, and 32 to without transplant being a heck of a lot lower, 5, 2, and 5. So really not even close, obviously statistically significant here. So quite exciting. While it's just these 3, while I'm presenting 3, we measured 8 short chain fatty acids and all 8 across the board were way higher, strongly implicating a change in microbiota function that's resulting in a significant increase in short-chain fatty acid production. So based on our data, we believe we saw a reduction in pathogens, an increase in short health-associated commensal bugs, and restoration of short-chain fatty acids. So super exciting. Our next steps, our manuscript for this is being put together. We are in the midst of our next phase 1 trial. The feeding tube is a barrier. We recognize that, but the purpose of that phase 1 trial was to show that we can actually do this, which we did, which we feel very confidently that we did in our 12 patients. But now we are testing it with our own Minnesota-made drinkable variety. It's a chocolate milkshake, fantastic, 3 ounces that we give on days 2 and 3 after surgery, which will then obviate the need for a feeding tube. Main question there is equivalency. Does it work the same? We don't know. We're right in the middle of that trial, so we'll have that data hopefully out in a few months from now. And then lastly, the impact on clinical outcomes. We do need the clinical trial next. It's great to have the microbiome. It's nice to have the validation of microbiome changes, which is where we had to start. Next would be, does this translate to a clinically effective outcome of reducing complications and enhancing recovery after surgery? So just want to thank our team that's been doing this. On the left is Dr. Chris Daly. He's my PhD partner. We share our lab together, and we've been working together for 12 years now. And then Dr. Koritz, who has essentially modernized and really been a pioneer in microbiota transplantation for the last couple of decades, my main mentor for the last couple of decade and a half. And then all our past and present residents who've just been I don't have enough positive things to say about them. I've been blessed with remarkable residents. Dr. Butts was our first research resident. She's now staff here, graduate of WashU. Dr. Boatman next is the chief, like I said, coming back at the University of Minnesota. Next up is Dr. Cohn, and then currently in our lab, Dr. Traster, Dr. Freebaugh. So these animals are coming around soon for sharing the good word of the microbiome. So with that, I'll be happy to talk about some stuff, take questions, go from there.
Awesome. Well, this is really, really cool work, and I think I'm excited to see kind of how the next few years shape out. I'll let some of the other questions come in through the chat. Dr. Anthony Squiralo says, Cyrus the
Squilaro.
virus. Cyrus the virus. Maybe that's how you got
Oh,
inspired. My question is kind of for you, how do you counsel patients, that are not in clinical trials to say, like, what is the role of the microbiome, right? Because I think that we focus on technical aspects when we're counseling patients about what we do to reduce leaks, but I don't know if you kind of go through some of this work with them as well.
I do, and I'm very honest. I tell them up front, and actually, funny enough, many of them already are aware of the role of the microbiome. So it's if they've done their research and all that, so it's actually makes things a lot easier. So I personally have talked to every one of these. We've now performed 19 transplants, including the oral equivalent. So I've personally talked with every single one in this study. It's nice having that intro that they get, and then I just share with them what our findings are and standard of care, and that I don't have any clinical trial data showing that it's improvement because we're just doing that initial study. But by and large, majority of them have been interested and kind of know what it's lending themselves into, and that we're doing something that, although new to the field of surgery, is
Mhm.
not new to the field of medicine. I mean, it's well established now in C. diff and all that. So framing it in that context, obviously, when you say phase 1 FDA trial, then it's a natural response to feel concern. It's new, is it safe, all that stuff. But in that context, they're much more amenable to it and agreeable, and actually excited because they've been
Yeah.
miserable. Particularly diverticulitis patients have been miserable for
Yeah.
years before. Yeah.
And they kind of know, sometimes they'll tell you like, I feel this attack coming on and like, this is how I modify my diet. And you're like, maybe you're onto something.
Yeah, yeah.
Um, Dr. Child says leaks are said to occur between days 5 and 10. How do we, or sorry, between days 10 and 14. So how do you kind of address that?
That's why I give the transplant on day 2. That's literally why. We have capsules for C. diff. We've studied that relative to the actual liquid variety. Capsules take 2 to 4 weeks-ish to engraft. From our data from C. diff, 1 dose engrafts immediately, and that's what we're seeing in our current data. So to that point, I was well aware of that. I want the benefit now because of that delayed
Effect?
leak risk. So, but you have to do it obviously after the standard of care antibiotic dosing. So we're giving it as early as we possibly can to induce engraftment.
Dr. I can't say this name.
Scolaro. Yeah.
Scolaro. He said, given the proof of concept, do you do anything in your current practice in addition to kind of mechanical and antibiotic bowel prep, and what is your protocol?
So that's a great question. What a smart guy. So not yet, but there are few modifications that I think should be coming down our field. I don't think neomycin and flagell, I mean, it's not thinking, I'm looking at our data, it's highly inadequate still. We need better coverage for enterococcus. We need to prove where and why that streptococcus is coming from. Both of them are still a giant hole in what we're doing. And so I think my biggest thing is I'm big. I mean, this is nice and simple, but protein intake a month before. I mean, as soon as I see him from the time of surgery, even if it's a protein shake or whatever, but not all protein shakes the same. I go with the high protein, low zero sugar stuff as a simple thing. I might put them on Citrussil as well, depending on their dietary restrictions with diverticulitis. I think that's a good prebiotic, kind of a preconditioning thing, but I'm not doing anything yet for those two just because I think I need to carefully study them to be a little bit more have a structured approach to getting that standardized. But I will be doing, I mean, this clearly needs to be done.
Yeah, yeah, that makes sense. Both pre-op and kind of post-op.
Correct, yeah.
Dr. Moslim said, this isn't a very nice talk. We see the impact of the microbiome and HPB, especially enterococcus and post-op pancreatic leaks. So I encourage you to explore this, especially for patients who are stented prior to Whipple or biliary work, which also does make a lot of sense.
We are looking into that actually. Yeah.
Oh, there you
So
go.
we have a big total panc auto islet transplant program here, and one of the things is biliary stasis and all the. So yeah, that's an excellent point. I've seen that literature. I think it was presented at Surgical Infection Society a year or 2 years ago, and it's interesting how our antibiotics are inappropriate for preventing pancreatic duct leaks, which in my days was still commonly, unfortunately, occurring. So.
Dr. Guyton says not all enterococcus is bad. How do you know that you're eliminating the right bugs?
Uh, so I recognize not all enterococcus is bad, nor is all enterococcus covered by the appropriate antibiotics that we're doing. So is I guess I don't. Are we saying with our current bowel prep? Is that the question? Like, how do we know we're not eliminating enterococcus right now? And right now, I am looking at the shotgun data to look at that specific speciation out from the enterococcus. So I get her point, but right now I haven't. We haven't done that specifically for the bowel prep data. So is this relative to? So if it's relative to hopefully the transplant setting, that we initially started off with the 16S and then moved to shotgun sequencing to look into it. I'd be happy to clarify further. I mean, she obviously is very well aware of the microbiome stuff, so but I'm happy to clarify that further. But we're looking at that through speciation with shotgun sequencing, and I agree with her.
I will let you know when I see an update on the chat. Um, what's kind of like the storage of some of these fecal transplants? Who are your suppliers? And between all the transplants, like, do you look at the diversity in the bacteria before administering. Does that make sense?
Yeah, so this has been a kind of a 15-year process where we've gone from where my mentor, Dr. Koretz, started in the basement of our hospital, which was just basically like poop in a blender. And so it's become a little bit more uh, yeah, sophisticated than that. At this point now, what I'll say is it's basically pharmaceutical grade. It's what we use in our oral equivalent for CETA. So we don't deliver it via colonoscopically anymore like what it used to be. Now it's delivered orally through either capsules or in the shake, which is free at this point. It's strictly freeze-dried microbiota. So it's freeze-dried, and then um, we mix it with literally 2% chocolate milk, and that's how we deliver it now. So we basically shifted that on over to the surgical population, and that's pretty much it. But the process has been going through a heck of a lot to get to where Dr. Koretz has made it.
Yeah, makes sense. Dr. Modi is asking, does prehabilitation, and I think we touched on this a little bit, change the microbiome?
I think Dr. Shogun is looking into that. I have not done, if I can take a guess, yeah, Dr. Alverdi's group has shown that in the mouse model, clearly that prehabbing is beneficial. In people, I would guess so. I don't have a good answer, but diets before surgery in people is an exquisitely difficult thing to change, and not only change, but to cause an impact in the microbiome that is questionable at best, in my opinion, based on some of our dietary studies.
Dr. Muslim asks, do you think that leaks start prior to the closing of the case? I remember Dr. Alvarez talking about an ointment to be applied on an anastomosis prior to closure. And I appreciate the way your chief resident designed the mouse trial.
I don't know. I'm not sure. I could only tell you that from our data, from intraoperative evaluation of the composition, which we would take at the beginning of a case, um, has has those Streptococcus and Enterococcus abundances in there. We've looked at that, and that composition, at least in our patients, is the same at day 0 as well as day 7. So um, they're there.
Mhm.
I would only assume that they're biologically imparting something, doing something. So that would be a very reasonable thought for sure. And then it takes its time, breaks down, and that's probably why you're seeing those leaks at day 5 to 10.
Mhm.
It's hard to argue ischemia for 5 to 10, especially with some of Dr. Alberti's videos that have clearly shown that. I think moving beyond that is important.
Fair. Um, do you have a sense of what the microbiota looks like for young onset colorectal cancer? And is it significantly different than kind of the older traditional cancer folks?
So I personally have not looked into that. I believe there are some differences there. I think that's still, I think early onset microbiome associated colorectal cancer, that field is pretty intensely being researched now. Um, I don't, I couldn't tell you if there are specific differences. I would assume so, since it's been increasing, but I could not tell you right now. That's a great question. Of course, from a left-sided, right-sided perspective with the age association, given the difference in pathways between the cancers, that my guess is I would assume there's a difference, but that's just a guess. I couldn't tell you more than that right now.
Fair. Well, we've had a very lively chat and sorry for the rapid fire.
No,
Um,
I don't mind.
it's been awesome. I don't think we have any other kind of questions on the chat. So I'll let you go for your Sunday evening, but thanks so much. This was awesome.
Cool. All right, great. Have a great evening. Thanks for having me.
Thanks so much.
Take care. See ya.
You too. Bye.